Good morning, dear friends. The topic of our today's lecture is the extrapyramidal nervous system. The extrapyramidal nervous system is responsible for the involuntary and automatic control of all musculature, such as muscle tone, balance, posture, and locomotion. On this picture, you can see how many structures of our brain are responsible for these very important functions. But the main parts of the extrapyramidal nervous system are the cerebellum and the basal ganglia or basal nuclei systems. We start from the cerebellum function, and we start by the cerebellum role in all processes in our organism. The main cerebellum function is regulation of coordination and balance. And the second very important function is regulation of the muscle tone. So, the coordination is provided by the muscle tone regulation. So, the main, very important thing is coordination by cerebellum of muscle actions together with relation of their antagonists. So, as a result, what is the main cerebellum function? The cerebellum subconsciously controls all voluntary movements, providing smoothness and harmonization. I want to revise familiar information about anatomy of the cerebellum, some words also about histology. The cerebellum lies in the posterior fossa, posterior to the brain stem and to the pons and medulla. The cerebellum consists of two laterally placed hemispheres and the midline structure, the vermis. The vermis is the oldest part of the cerebellum, and it is responsible for static or truncal coordination. Hemispheres are the newest structures of the cerebellum, and they are responsible for the dynamic function and limb coordination. The cortex of the cerebellum is much folded. The folds or folia are separated by numerous transverse fissures. Each folum has a core of white matter and the outer covering of gray matter. The cut surface has a branched appearance called the arbor vitae, tree of life in English. Intracerebellar nuclei. 4 masses of gray matter are embedded in the white matter of the cerebellum on each side of the midline. From lateral to medial, these are dentate nucleus, emboliform nucleus, globose nucleus, and fastigial nucleus. In Latin, nucleus dentatus, nucleus emboliformis, nucleus globosus, and nucleus fastigial. The very important role the dentine nucleus has comparing with other nuclei, because all descending pathways start from the nucleus dentatus. On this picture, this nucleus has a red color. The cerebral peduncles Three peduncles connect the cerebellum to the brainstem. Superior peduncle to the midbrain, and these peduncles are crossed. The name of this cross is Wernicking, and the middle peduncle goes to the pons, and inferior peduncle goes to the medulla oblongata. Superior cerebellar peduncle crossed contains all the cerebellar thalamic fibers. Middle cerebellar peduncle contains only pontocerebellar fibers. And inferior cerebellar peduncle contains olivocerebellar fibers, dorsal spinocerebellar tract, and all the fibers connected with the vestibulocerebellum. The cerebellar pathways. The spinocerebellar pathways, or in Latin spinocerebellar, form a method afferent input. These transmit some conscious proprioception from muscles, joints, and skin. Let's revise anatomy of ascending and descending tracts. We know there are two ascending tracts. The posterior spinocerebellar tract or flexic tract. Dendrites, receptors receive information about position and flexion of joints, for example, or muscles in our body, and pass this information to the first order neurons. You remember all first order neurons for absolutely all sensory tracts lie always and only in the spinal ganglion. Axons of these neurons enter the spinal cord, enter the spinal posterior horn, and form ipsilaterally without crossing posterior spina cerebellar or dorsal spina cerebellar or flexic tract from the Clark's cells, which lie, there are second order neurons which lie in the posterior horns. So this tract ascends ipsilaterally and through the inferior cerebellar peduncle. This tract goes to the ipsilateral hemisphere of cerebellum. So, the conclusion: posterior spinocerebellar tract conveys sensory information to the same side of the cerebellum. The second ascending spinocerebellar tract, ventral or anterior or Gover's tract. Do you remember, first order neurons always lie here in the spinal ganglion. Then this tract enters the spinal cord, gray matter, posterior horn and cell bodies of the second neurons lie in base of the dorsal horn of the lumbosacral segments here. Axons of this second order neuron cross the midline to opposite side and then make the superior and then form the anterior ascending spinocerebellar tract up to the pons, and then with crossed superior cerebral peduncle cross the midline again, and this tract goes from the opposite to the same ipsilateral side again and terminates on the ipsilateral side of the cerebellum. So we have the same situation like in case with the dorsal uncrossed flexic tract. Ventral or anterior or Gover's spinocerebellar tract conveys sensory information to the same side of the cerebellum also. Without cross or with cross, the same situation, to the ipsilateral side. Efferent pathways. Only one cerebellum descending tract, tractus dentarubralis, from nucleus dentatus to the nucleus ruber, with the superior peduncle. But we know the superior peduncle is crossed. So we go to the contralateral side again. From one hemisphere, for example, right hemisphere of cerebellum, to the opposite, for example, left nucleus ruber in the midbrain, in the cerebral peduncle. Next part of the descending tract, rubrospinal tract, starts from the red nucleus in the midbrain. Then this tract makes a decussation once again, infranuclear decussation, or decussation by Forel decussation. And this tract decussates the midline again and goes down in the lateral funiculus up to the anterior horns, and then with anterior roots exit the spinal cord and goes to the muscles for regulation of their tone and coordination of movements. So, summary. Ascending tracts. In case of posterior tract, this tract doesn't have decussation. In case of anterior tract, two decussations. We start from, for example, left side, and information goes up to the ipsilateral left side. Okay, come down. Dentarubral part of descending tract. One decussation. Wernicke decussation with superior peduncles. And the second part of descending pathways. Manakov tract or rubrospinal tract. Also one decussation. Infranuclear decussation. Forel decussation. So we have again two decussation of descending tracts. And we again come ipsilaterally for regulation of muscle tone and coordination. So, summary. Damage to hemisphere structure always produces signs ipsilaterally to the site of lesion. Compare with, for example, pyramidal tract or somatosensory function. In that cases, we always have contralateral regulation and contralateral signs of lesion. In this case, we have ipsilateral regulation and ipsilateral signs of lesion. So, what are these signs of lesion? Signs and symptoms of cerebellar pathology. The next part of our lecture. The first symptom and the main symptom of cerebral dysfunction is ataxia. Do you remember this Latin word? We described ataxia when we discussed somatosensory pathology, deep pathology, and sensory ataxia. Ataxia means disbalance or disequilibrium. We know several types of ataxia. Sensory ataxia, we discussed. In this case, cerebellar ataxia, maybe vestibular ataxia, cortical ataxia, but I can say the cerebellar ataxia is very, very bright and very difficult and very original in clinical picture. Damage to midline structure, vermis, results in disturbance of equilibrium with unsteadiness of standing, walking, and even sitting. The name of this ataxia is truncal ataxia or sometimes static ataxia. How can we check? By a Romberg test. Ask patient to stand with the heels together. Note any excessive postural swaying or loss of balance. In this position, or in this position, hands down or outstretched. Both positions we can use in our clinical practice. You see, swaying ipsilateral to the side of pathology in case of unilateral damage of cerebellum. What is very interesting, eye closure does not affect balance. Why is it so important for us? Because when we discussed the sensory ataxia in case of proprioception pathology, it was said with open eyes, patients can control by vision, by sight, position of their legs, feet, of the ground, and they are always better with open eyes and worse with closed eyes and in the darkness. In this case, eye closure does not affect balance. So, this is a differential diagnosis between sensory ataxia and cerebellar ataxia. Damage to hemisphere structures always produces signs ipsilateral to the site of lesion. The patient complains of impaired limb coordination and walking, dynamic ataxia. Main symptom is ataxic gait. In this gait also doesn't matter with open eyes or closed eyes. This is our patient with cerebellar ataxia, swaying, reeling, unsteadiness during walking. Methods of checking of ataxia in extremities, upper extremities, finger to nose test, or sometimes finger nose test. Ask patient to touch his nose with finger. Eyes may be open, may be closed, doesn't matter. Look for two main pathological symptoms: intention tremor and dysmetria. Intention tremor, jerky movements which increase as the limb approaches its target, approaching nose. And dysmetria, overshooting the target when performing this specific motor task. Point-to-point movement evaluation, similar to finger-to-nose test. Ask the patient to touch examiner's finger, but it may be a little bit difficult for patient when we move our finger and ask the patient to touch it. And pathology is the same: intention tremor and dysmetria, overshooting, extra movement. How can we check ataxia in lower extremities? Heel to shin test, or heel shin test sometimes. Ask the patient to elevate his stretching leg, put down to the knee, and move the heel along the shin towards toes. Look for similar symptoms: intention tremor and dysmetria, overshooting, extra movement. This is the picture of this test and our movies.
Видите. Теперь то же самое с другой ногой. Давайте. Стоп.
One more patient, our movie.
Пяточкой попадаете в колено. Проводите вниз по ноге. Резко положительно пяточек коленной правой, другую ногу таким же образом. Все, уже. Сейчас спину сниму.
There were two patients with alcoholic, toxic, cerebellar ataxia. Chronic alcoholism always affects the cerebellum, and the cerebellar ataxia and cerebellar atrophy on the MRI and CT scanning is a result of chronic alcoholism. The next symptom of cerebellar ataxia in upper extremities, dysdiadochokinesis or kinesia, or adiadochokinesia. In Latin, dysdiadochokinesis or adiadochokinesis. A failure to perform a rapid alternative movement, supination and pronation. Ask the patient to rapidly supinate and pronate the forearms, or to perform rapid and repeated tapping movements. One more, our patient. With adiadocho or dysdiadochokinesia. The next sign of the cerebellar pathology, it's nystagmus. Nystagmus is defined as an involuntary to and from movements of the eyes in a horizontal direction. Eye jerks occur to the site of the cerebellar damage ipsilaterally, like all cerebellar symptoms. This is nystagmus. Eye jerks in horizontal direction. One more symptom of cerebellar pathology, disturbance of speech, scanning dysarthria or explosive speech may occur with speech occasionally delivered with sudden, unexpected force. Articulation is jerky, and the syllables often are separated from one another. Dysarthria occurs in cerebral disease owing to ataxia of the muscles of the larynx. What is it scanning? Scanning, dysarthria, or explosive speech. And what is it dysarthria? A pathology of articulation, discoordination of articulating muscles, like dysarthria, acute cerebellar disease. So, in case of cerebellar pathology, sometimes patients have a combination of these two variants of speech pathology: scanning speech plus cerebellar dysarthria. For cerebellar pathology, the muscle's hypotonia is typical. Let's revise familiar information. How can we check muscle tones? By passive movements of extremities, flexion and extension. What is it? A cerebellar muscle hypotonia, diminished resistance to passive movements of joints. We can observe, in case of cerebral pathology, Stewart-Holmes rebound phenomenon. Ask the patient, in this position, for example, to flex elbow against resistance. Sudden release may cause the hand to strike the face or chest. due to muscles hypertonia. Pathology of handwriting due to muscles hypertonia, dysmetria, discoordination of hand and fingers due to bold hand. In this case, we have megalographia, writing labored and slow, letters irregular in size and enlarged. Very interesting phenomenon was described by famous French neurologist in the end of 19th century in Paris, Babinski. And Babinski named this phenomenon like Babinski's asynergia. There are pictures from their book published in Paris in 1999, and they were first photos, not pictures, but photos in neurological book with photos of cerebellar patients, ataxia of these patients. What is it? Asynergia. Absence of coordination of organs or body parts that usually work together harmoniously. In this case, asynergia on different muscle groups during performing special motor task. In his original description of cerebral asynergia, Babinski in 1899 presented a patient with cerebral dysfunction performing a backward upper trunk bending. When the patient tried to bend his head and trunk, his lower limbs stayed almost motionless because the associated flexion of the knee and hip, usually observed in normal subject, did not take place. How can we check Babinski's asynergia in our practice? The patient is in supine position, like on this picture or in that picture. Cerebral patients are unable to sit up from a supine position. The hip flexion is not associated with a leg extension. In this case, the legs are raised above the bed. Babinski also showed several examples illustrating the lack of simultaneous flexion of the hip and knee. There is important to remember that in cerebral lesions there is no paralysis and there are no sensory changes. Although muscle hypotonia and incoordination may be present, the disorder is not limited to specific muscles or muscle groups. Rather, an entire extremity or the entire half of the body is involved. Then the entire body may show disturbances of muscle action. Even though the muscular contraction may be weak and the patient easily fatigued, there is no atrophy. So, we have discussed the cerebellum pathology, and you see There are two main functions of cerebellum. There are the first function, coordination regulation, balance regulation in organism, and the second function, which can help the first one, it is regulation of muscle tone. For basal nuclei or basal ganglia system, the second main part of the extrapyramidal nervous system, the regulation of muscle tone is the most important function, and we will discuss and describe the anatomy, pathology, functions and dysfunction of the basal nuclei system in the next second part of this lecture.